Hello, everyone. Welcome to Health Talk Show. I'm Dr. Farhanta here, joining you from Philadelphia. Today, it is my pleasure to invite one of my friends, Dr. Atul Kalanuria. He is an
Hi, Brian.
assistant professor of neurosurgery, neurology, anesthesia, and critical care. And my friend, welcome. Thank you for joining.
Thanks,
Um,
Brian.
Atul, I want to ask you about COVID-19 and how it's affected neurocritical ICUs. I would love to know your experience of COVID and how you have managed these cases and shared some stories so that we can learn from your experience.
Sure. So, like most intensivists across the country and across the world, we as a group were also redeployed and we were taking care of patients who were affected by COVID in an ICU setting. And this is usually, not something we do. I'm a neurointensivist, so I really take care of acute care neurology. But because I'm also an intensivist, I was expected to take care of these patients. And it has been a unique and very sort of hardcore learning experience for me because, to be honest, some of the things I learned along the way with these patients is not something I've seen before. So, some as over time as a physician, you develop a reasonable amount of experience and you get a sense of what the lung is going to do next and how do you manage it. But in this case, I must say that some of those theories and experiences were of no use to me because the virus and the way the virus inflamed the lung were so different than what I've seen so far.
Wow, well,
Yeah.
that's intense, and I want to dig deeper into them, into these stories. As a neurocritical physician, you deal a lot with the brain,
Mhm.
but now you're being asked to do critical care, ICU care patient.
Mhm.
Uh, what are you seeing the main target organs getting damaged or affected by coronavirus in your ICUs?
I think the top three would be the lungs, obviously. That's usually
Hmm.
the entry point. And then we've seen a reasonable amount of cardiac and renal dysfunction in these patients.
Interesting.
And
So what
yeah,
do you see in lungs?
so typically, viral pneumonia has a certain way that it affects the lungs. In this case, we the CT scans showed a widespread inflammation, really quickly. So, even with supportive care and support, preventing inflammation, the lung still got pretty severely inflamed in the severe cases that I saw.
So is that the
Um,
term they use, acute respiratory distress syndrome, ARDS?
so
Is that what
it
you
could lead to
leads
ARDS.
to? Okay.
Yeah,
Okay.
yeah. So we
So
saw a
how
lot
many
of patients.
days usually it takes for people when they start requiring oxygen to ARDS on average, roughly? What is your experience?
So my experience was, and this is only my experience based on those few days I took care of the COVID patients, is that there was no sort of timeline, and
Okay,
that
so
was
it
the
could be
tricky
any
part.
time.
It
Yeah.
could be somebody who came in. I'll give you some examples. I had a patient who came in from the emergency room, was admitted, and within 24 hours developed severe inflammation of the lungs. And
So there was nothing that you could tell this patient, like, how we
no,
used to like have gauge sepsis criterias and
correct.
send this patient to ICU. So this is unpredictable. Like you could say, oh, this was stable, go to floor, and then 2 hours later, the patient is crashing.
May not be 2 hours, but you're right. Within a short amount of time,
So
would
it's
be requiring more oxygen and then come to the ICU. Conversely, we had patients who had a significant amount of injury evident on a chest X-ray or a CT, but did not require intubation. So I saw both ends of the
both ends
spectrum,
of it.
and yeah, and
As a neurocritical care physician or as an intensive care center, can you, and I believe this talk would be mostly for the physicians, could you dig into some labs that you saw as a initial labs and how they progressed over a period, that maybe keeping one, two
so
patients in mind?
yeah, there weren't any specific lab tests that I can think of. But in terms of the organ damage that we talked about, we did see some degree of myocarditis, and we did see some degree of renal failure. So the labs were corresponding to those.
To that. So I've seen they are asking people to get a complete blood picture, CMP, which is very common for
Mhm.
liver and C bone marrow function. But they're also asking to do C-reactive proteins, LDH, ferritin, FDP, D dimers, and prothrombin, PTT. What is your comments on those labs?
So I think the markers of acute inflammation did not really help guide my therapy. What did help guide my therapy was looking at some of the coagulation numbers.
Okay.
So yeah, there is. We already knew that there was literature out there that suggested that patients affected severely with COVID had a higher propensity to clot. And so we were looking at the coagulation profile frequently. I was performing a lot of vascular ultrasound studies on these patients just to make sure that if there is a deep vein thrombosis, then we catch it early and act appropriately.
So how can we tell if people have more hypercoagulability, like two COVID patients, one who is have hypercoagulability more than other? What test can help us like think for that?
There was no, so you get the prothrombin time, the activated prothrombin time. You had the international normalized ratio. You look at the liver
Do they
prothrombin.
decrease or they increase? Because usually we monitor them for anticoagulation. Like if I'm giving heparin, I'm watching APTT to go up. In COVID,
So
what those numbers represent?
So by themselves, they don't represent anything, but we had a protocol where we treated most of these patients with a heparin infusion, not to full dose, but between a certain level.
Okay.
And
So you
so,
use those numbers to monitor your therapy,
correct,
but you couldn't tell if this patient should be treated because he's more prothrombic. So there
correct.
is, like, we use sometimes D-dimer as a
Yeah,
test in our emergency rooms
yeah,
to check for PE if somebody's in shortness of breath. Is that a good marker to say or no?
no.
No.
Yeah.
And how many of these patients, in your cases, were surprisingly were having pulmonary embolism? Were these protocols done or only when indicated?
So we had some advantage because we had reports from northern Italy and China and some experiences by speaking with the physicians in Italy, and we knew that these patients have a higher likelihood of getting clots, and so we were able to be more vigilant and treat them in time, um, and we were more aware, I would say. There
Okay.
was also reports that these patients were bleeding in the lungs, based on the way the viral
So you have to be
inflammation.
careful with pulmonary hemorrhage too.
Correct.
Um, now, couple of questions on infection prophylaxis or infection treatment. You just, as we all do, like, broad spectrum antibiotics, was there anything different you were doing for these
No,
patients?
no. We only
No.
treated if they were infected with a bacterial,
Infection.
pathogen.
But prophylactic, like, how we say, well, the patient has infiltrates, and if traditionally if we were not checking for COVID, we would put them on antibiotics. Was that the way you guys were
No.
doing that too, or no?
So we don't have a standard practice. Everyone does things a little differently.
Yeah.
I'm very conservative with my antibiotics, and so unless I have a very high suspicion or a confirmed source of infection, I usually don't treat with antibiotics.
Interesting. Okay.
So I don't do prophylactic antibiotics.
Ventilators and
Yeah,
care of ventilation, do you manage them or pulmonary doctors are coming to come and
we
help?
manage them.
You manage them?
Yeah.
Wow. Okay. So any interesting things, any difference in these patients than regular
Yeah.
person?
Yeah, what I can say is that you mentioned ARDS, and a lot of these patients met the criteria for ARDS. But as you know, that for ARDS, there is a protocol that most people internationally follow. It's the Berlin criteria, and a lot of these patients they met the criteria for ARDS, but did not need that protocol. We some like the protocol suggests we should be comfortable using a very high PEEP on the ventilator, and we should be tolerant of high carbon dioxide levels in the blood. But to be honest, even though these patients, the ones I took care of, met criteria for ARDS, none of them had a high carbon dioxide level in the blood, and they did not require high PEEP. So what they had trouble with was oxygenation. And so our focus was completely in that direction.
I've heard and talked to some critical care physicians, and they were trying to keep patients prone.
We had
Uh,
a few patients like that.
so, have you were you doing that practice, and was it
Yes.
useful?
Yes. In some patients, it was useful because, especially when we started early, and we essentially made it part of our care package.
Okay, so you were. Well, is it a special kind of bed that the people have to be put on?
The bed remains the same. There's a certain pillow or sort of structure that we can use to keep their face
Okay.
sort of not, so that they don't smother.
Um, I'm I'm gonna ask you a question about the new novel treatments that people have tried. Remdesivir. I was in ICU covering a patient 2-3 weeks ago, and of course a critical care physician was helping me. We were co-managing, and the patient was already on remdesivir, and then they added Actemra, which I know from as a rheumatologist. Have you used them, and what was your experience?
So we, when I took care of these patients, remdesivir was still being studied,
Okay.
and so we had a few patients who qualified for the study, and so they were getting it as a study drug. And it's only after that that now we're hearing that remdesivir is proving to be effective in these situations and against this virus.
Yeah.
The other medication you mentioned, I'm not quite. You mean hydroxychloroquine?
Tocilizumab, the IL-6
No, we don't use
blocker
it.
for the crisis of cytokine storms.
I did not use that.
You didn't use it, okay? Uh, because some patients have been found to have like high inflammatory markers, and they block that use of these agents that are traditionally used for rheumatology, but they're starting using it. Um, how has that affected? Has it touched you as a in ways of like, have you had to take care of, I hope not, but a physician, a friend, a coworker, a healthcare provider who got affected while taking care of those patients?
Yes. So I I can give you two examples. One is one of my close somebody I worked with essentially tested positive, and that person was taking care of COVID patients. So that person had to be quarantined for a certain number of days. Thankfully, there was not much of a
Severe
symptoms
symptoms, yeah.
progression.
Yeah,
So we got away with just staying at home for a few
good,
weeks.
thanks.
But
Yeah.
then I have another friend who doesn't work with me, but came in contact with a COVID patient, and he and his mother had to be hospitalized. His mother was in the ICU, intubated, and he was on oxygen for a few days in the hospital, and his entire family tested positive for COVID. So I know some people.
Yeah, it touches. I've one of my colleagues got sick,
Yeah.
and he had to. He was for 6-7 days or 5 days. He was in at home, but his oxygen saturations continued to drop, and he had to go to emergency room when he was in, I think, like low 90s, in high 80s, and he was at that day of verge where 8 days were about to be over, and they were not gonna give him remdesivir,
Mm.
but eventually they tried, and it made a difference, and he
Okay.
recovered after 6-7 days in
Good.
hospital, and now he's back home recovering. So it could be serious, and
Yeah.
a lot of physicians are talking about post COVID stress disorder for healthcare providers. As a director for ICU neurocritical care, what are you seeing in your health team members, and
So yeah,
what do you
you're absolutely
suggest?
right. Thankfully, we our group was very quick to recognize that this could become an issue.
Hmm.
And so we set up a small team of trainees and nurses and nurse practitioners, and we tasked them with the wellness surrounding all the team members. And so they were responsible for accumulating and assimilating all the information and resources from a wellness standpoint, and then disseminating it to the rest of the group. So we
Good.
had that
You
part
had
going.
that. Okay. Um, any neuro complications of COVID that might be that you might have seen and you may say, well, this is unusual. It could be COVID. I know it's very difficult to say for sure until we have more proven autopsies and other things. But just by your own clinical hunch, what do you see? Is there any neuro
No, I know that there were reports initially that you know something from the
delirium and psychosis and confusion and strokes and all that kind of stuff? I
we
mean,
heard
even
about,
up to date is mentioning those.
right, and out of those, delirium and psychosis and things like that are very common in ICU patients to begin with. So I
Yeah.
don't think it's directly correlated with coronavirus, but um, like you said, we'll have to just wait for more studies to come through to tell
Mm.
us what this actually did. But no, in particular, did I see anything neurologically? No, I did not.
Okay. Okay.
Yeah,
All right. Well, I want to say thank you for all the services that you did. I know that you are at that point where you have to deal with the secretions that are actually more aerosol, and it's hard to be more infected. And as a physician, taking care of critical care patients with intubations and all that stuff, you put yourself at harm's way. And may God protect you and reward you for the services you're
you too as
providing,
well.
and hopefully you stay healthy. Thank you so much for
Oh,
sharing,
most welcome.
your insight. I feel like that my take home message from you is that if if somebody is in hands of good, responsible, conscientious doctors, patients are likely to do well. Life is in no one's hand, but I think that if well-trained, good physicians are able to manage and respond appropriately to what's happening, that's probably the key, because you can't make a judgment for everybody's gonna behave like this. As you said, COVID is surprising in that way that it could be different for each individual.
That's right.
Okay. Well, with that being as the, is there anything that you would like to share with us at this point in terms of overall, message to the world who are listening to you in regards to COVID? Do you think people should continue to observe what CDC has recommended? Because a lot of people are now confused. Should we be observing? Should we not be? What is your take on it?
I think, be cautious and aware at all times, even after reopening. There's a lot of smart people who are making decisions about reopening the states and borders and things like that. But eventually, the responsibility is with the individual on,
Yeah,
how much precaution they'd like to take.
yeah,
So at least until we have more information, do wear a mask, wash your hands, and you know,
yeah,
maintain.
yeah. I think those are the basic things that go a long way.
Yeah, yeah,
Eventually, most people would get exposed to some way or the other to develop the immunity. But
right.
yeah, just okay. Very good, Atul. Thank you so much.
You're most welcome, Farhan.
All right.